Integrated care at the neighbourhood level, for me, has to start with getting frailty right for those who are mild, moderate, and severely frail. Just been through that process with my father, who died in May, and it's a tough old process, but it's essential we do that for everyone. Here's where I think we need to change our perspective.
Meet Matthew Winn, Chief Executive Officer of the East of England Community Health and Care (NHS) Trust and Member Board of Trustees at Cambridge United Foundation, also the host of the Leadership and Culture in Healthcare podcast and a former national NHS leader. Matthew has spent years driving community healthcare transformation alongside key policymakers.
We're only employed as public servants to do one thing, and that is to do our role to support great health and care to be delivered. Great, well-performing teams are far more likely to deliver great care to the individuals, to the punters, to our patients, than dysfunctional teams.
The challenge and the opportunity of almost reinventing how we deliver, how we support people to be healthy, and then we deliver care across health and social care in its broadest way in integrated neighbourhoods and places is a very exciting challenge. Is there a particular leadership role that you think you're looking for your trust to help in creating integrated neighbourhood working?
There's a massive evidence base about
Well, it's great to be joined this morning by Matthew Winn. Thank you very much for joining me. Matthew is the Chief Executive of the East of England Community Health and Care NHS Trust. He's also a podcast host of the Leadership and Culture in Healthcare pod, which is a great listen. Matthew's also been the leader before of community health and care for the NHS at a national level. So he's worked closely with leaders and policymakers, as well as having been a chief exec for many years, particularly in the East of England. So Matthew, thank you so much for joining me.
My pleasure, Alastair. Good morning. Hi.
It's great. Well, I'm going to start off with a question I ask everybody, which is really, lots of people use the term operating model differently, but what does it mean to you as a chief executive?
We've just gone through a process of merging two organisations into one to create the East of England Community Health and Care Trust. And we're thinking a lot about our operating model. And I think it's not one thing. For an organisation like ours, who operates from Great Yarmouth and Lowestoft in the east all the way over to Milton Keynes, so we've got a big geographical area, we have to work and we do work in a very delegated way. We have to work in business units. We have to train and trust and equip our leaders to lead and make great decisions and run their areas of work with probably minimal interference. And I think the other aspect of that for central teams, some people call them corporate teams, that not really my language, but is that they're there to enable our teams to flourish. And in the organisation, I'm always talking about all our roles we're only employed as public servants to do one thing, and that is to do our role to support great health and care to be delivered. Otherwise, we have no purpose in the organisation. So it's that thing of pointing to the end point, and everything we do therefore needs to support that to happen. Now, that's really simple to say. It's pretty hard to pull off, because that means it's a whole culture, it's a whole training, it's a whole delegation process. It's real making sure you've got grit and you've got the kind of glue that binds that together. So, and I think more importantly in that all comes together to create one culture that works, that delivers healthcare. There is the possibility where you have that fragmentation, that you then just go into fragmented units that have no commonality, and you've kind of lost the point. So our operating model is multiple jurisdictions, differences between adults and children care, delegated out by kind of county area, given we're in shire areas, and support those leaders to make great decisions. And then finally, proportionate board oversight, but making sure and understanding, especially for our non-executives, that they understand some of the undercurrents of what's going on in our divisions, not just the high level, which therefore could flatten out a whole heap of issues that are prevalent every single day.
Yeah, no, thank you. So can you say a little bit more about governance? So I'd be intrigued. So you've always, I think, led organisations that have been pretty flat and tried to empower leaders. This isn't a new way of operating for you. So I'd be intrigued, one, why you're choosing to do that, and two, how often, if do you find you have to get involved in a particular patch for any reason?
It's always a balance. So our structure is that we have our executive, so normal chief nurse, an AHP officer, medical director, HR, chief people officer, finance and resources. We've got a strategy lead, and we've got a recently, since we've been together, a chief information officer and digital lead. So we've got a small executive. Then we have service directors leading those divisions that I just described. So we don't have a chief operating officer.
Right.
And that is potentially unusual. We're not the only organisation that doesn't have that role. The reason we don't is because of that geography and that span. There's the distinct risk that they become the single point of failure or axis in everything, whereas this is a team sport, and we need our chief information officer, our finance director to be intricately involved in the conversations in every division, not it being a single director responsibility as a coup. So that's what we do. We therefore remunerate our service directors well to get the right caliber of people and get them to be leading their areas. And then it's kind of the inverse that you get in some organizations is our service infrastructure and our service support structure wraps around them. We then at board level have things called service assurance committees. So we've actually got 3 of those, one for children's, one for Norfolk by itself, and one covering Bedfordshire Luton, our ambulatory services. And there we bring together finance, quality, people, performance information. It's chaired by non-executives. There's probably 2 non-executives, 2 executives, and then service directors and clinical leads for all those areas, where they understand that point about undercurrents, a clear escalation into the board, and an integrated board reporting that then mirrors that approach for the aggregation of the organisation. How much am I involved? I think it depends on the different areas and the issues that they're facing. I happen to directly line manage 2 of those service directors. Other directors, execs, directly manage other service directors. So of course I'm probably more involved in those areas because I've got a line management responsibility. But that's again proportionate to what is needed, but always for me making sure that I'm not undermining my leaders to actually do their work. I'm adding value. I'm bringing the other execs in to make sure we do that. And I can continue to be strategic in approach rather than necessarily in the weeds with people. But of course, Alastair, if I need to be in the weeds and go out and understand as I regularly do, that's exactly what I shall be doing and will always do.
Yeah, sure. So obviously this model, which is different from other people, and I can understand it's particularly needed where you're serving multiple geographies with their, and we're hearing a lot about place nationally at the moment and the kind of devolution. So we're only going to hopefully have more of that. But to make this model work, I would have thought you're critically dependent on your leaders and creating a framework that they can thrive in. Do you want to say a little bit more? I mean, I'm assuming, therefore, that leadership development is a really important part of your approach.
Oh, absolutely. So, I mean, it doesn't work without great leaders. I don't think we're unusual to anybody else.
No, it's probably
No
everybody, isn't it?
organisation,
Yeah.
whether it's clinical leaders, managerial, professional leaders. So, yeah, we have spent both in previous organisations as now as a merged organisation, I think an enormous amount of energy, rightly, and will continue to do that on both leadership development, culture working to our value base. And we do that because the evidence shows, and anybody can find this evidence, that great, well-performing teams are far more likely to deliver great care to the individuals, to the punters, to our patients, than dysfunctional teams. So it's not surprising, therefore, that any healthcare organisation or social care organisation should be spending an enormous amount of energy on making and supporting their teams to be great teams, functional teams. They're not all going to be buddies. Of course they aren't. That's not life, is it? But they can be respectful, they can be inclusive, and they can be professional when they're at work, and they need to be, because those are the ingredients of allowing teams to thrive and provide great care. So we patrol and we manage behaviours really tightly. They're absolutely behavioural statements that are not draconian, they're supportive, but they are, then the conversations happen if people are not behaving within that, in that way, because again, that's insipid. It undermines the culture of teams and our work. We have for years now developed our own internal Chrysalis leadership program. And we have other people going off to do other things, master's level things, the national programs, which are all great. But fundamentally, if we can train and support our leaders with leadership capability at the very junior level, we're far more likely to be successful. They will not need and will not want, frankly, people like me coming in, because they know their trade and they can get on with it. When they want support, they can have it. I think this year coming up, we will now have 4 cohorts going through that. It's a kind of half-year program where they do days and they're in action learning sets, and we run that ourselves and have honed that down. And, it's, for me, it's one of those unmissable events when they graduate. I've never missed one. I speak twice at those leadership events during that time, as do all the other directors, to support people. Frankly, without that type of support, we won't have great leaders who are going to thrive. And I would say that is one of the key ingredients for having a delegated of responsibility, because if you don't train your leaders, they won't be able to do that work and take the responsibility.
And you're obviously in the middle of a merger. Well, sorry, you've merged and you're in the middle of making the new East of England Trust kind of really work in line with that approach. And you've got very different local contexts to some extent that they're working in as well. So how was the process of harmonizing culture and ways of working across the two trusts? Kind of how's that going?
It's in progress,
Right.
I would say. So for those that listen, a year before we merged, we formed a group model, and I've seen lots of stuff written about groups at the moment, and it's interesting people's perspectives on groups. But we formed our groups to have, and we maybe did again differently to others, but we did learn from things that had gone well or had gone wrong in the NHS. So we created one executive and one non-executive board a year before we merged. So we worked as under a group name, but 2 statutory organisations. So there was change at that point. Some change happened during that year prior to merger, of people bringing teams together and understanding how things could work in one way. Some things were done jointly. Some things had to be done separately, like audit committee and remuneration committee, but quality committees and things like that could be done together. And then the technical merger happened on April the 1st. The NHS England team kind of saw us twice. When in the statutory NHS world, when you form a group, you need the agreement. And Miranda Carter in NHS England, who's fabulous and has got a great team, takes you through that process. The same team then came back to approve our merger and get the statutory approval to do that. We're now, I think, in the hard work of harmonization, and you use that word, and that's what it is. So harmonization's correct for most things, but actually for lots of areas, it's about then forging a single new way. And it gets very divisive at times. in these interactions to say, oh, is it the old organisation A or is it the old organisation B? And kind of green-eyed monster comes out. No, we're going to do what's the best in class. We're going to do what the evidence shows us is the right way to do it. We're not going to replicate things that actually won't work in, whether they came from either previous organisation. And that's the approach we're doing. Interestingly, whilst we're both predecessor organisations were both community organisations, they were neighbours, their portfolio is ostensibly the same, but not exactly the same. They got pretty similar size, pretty similar ratings from regulatory world. They were very different in their culture and how they operated. Financially, very different approaches. Workforce-wise, very different approaches. Clinical governance has been quite different. So it has been that kind of assimilation, that harmonization of, look, what are we doing? How are we doing it? It's allowed all of us just to refresh and just say, is that the right way to do it? Because we're going to have to rewrite these policies. We're going to have to reset some of these things. And I think that will take probably another 18 months to 2 years. Some of it will take longer. We're locked into some contracts that will go on and we can't come out of. We'll do things like merge our electronic staff register in October. So we chose not to do that on day one because there's the risk that people won't get paid. Probably the worst thing to do on day one of a merged organisation is not pay everybody. So those things will come later on. But yeah, we've got a very long plan that just keeps on going through those things. I think finally the both, and you could say this is sad but really helpful. What the important thing is that merged organisation a better place to deliver health and care services? The only reason to merge is, are we in a better position to do that? And when I'm out and about, as I regularly am, and I talk to clinicians, they now know things have changed, because before it was kind of lost on some people. It really impacts central people more than it does the kind of jobbing clinicians who are out and about in people's own homes every single day. And some of them were oblivious to it. And in some respects, I think that's quite great. I think this is brilliant. You haven't been nothing's kind of stopped you from doing your job. But now it's become real because we are talking about standards as one organisation. We are now saying, actually, data collection needs to be the same across the whole organisation, and you're now going to be collecting information or need to collect information, or we need your view on what the right clinical way of doing it is in Luton and Bedfordshire and Norfolk. And those people have never met each other. But that's fine. That's quite good internal challenge to say, actually, are we the best in class in doing these things? And that then becomes real after you merge and you start doing those things together.
So you've got that dimension of kind of merger and creating this larger organisation with all those possibilities. At the same time, I'm very aware that your organisation will work in multiple localities, I think all of whom I have at various stages worked in, and I can testify they're different in terms of geography, in terms of demography, in terms of how local people think, in terms of politics, in terms of services. So, that how do you have community integrated care organisations working in different local contexts, and you still get a consistency of standards, governance, and yet you can be flexible to the needs of the local population if you're the service director or your place lead. So it's how do you get that consistency and local flexibility really working?
Yeah, and that's a good balance to get right, and it is a balance because it's never static. I think that delegated leadership helps that approach. So our leaders their jurisdictions map onto current local authority boundaries, and one of our challenges is in Norfolk, in Suffolk, in Cambridgeshire and Peterborough, local government reviews are going to fairly fundamentally change those local government boundaries, and lots of our work, whether it's in children's world, SEND, health visiting, sexual health, and adults and older people services, all are kind of key partners with local government. And indeed in Norfolk we have a very mature Section 75 where we have integrated approaches around the adult social care workforce. So you have to have that local leadership and those relationships. And therefore, you have to go back to that point, support leaders to be able to do that. I think, though, within that, there is something very hard and non-negotiable about standards of care. So if I'm talking to our health visitors, we have health visitors across the whole of that patch, enormous set of, I think it's probably one of our biggest single professional groups, fabulous crew. I will always say to them, as we always say to them, is, look, we expect your professionalism, your standards of care, your adherence to the Healthy Child Programme and the evidence base underneath that, the local safeguarding policies, the interaction with midwifery and into primary care and early years in social care and into the councils, to be absolutely clear. And we expect that to be the same wherever we do it, because that's non-negotiable. But we expect you to bend and change your approach according to your demography, according to the needs of the population, whether that's faith, whether that's ethnicity, whatever it is. If you're in Luton, over 100 languages spoken. Yes. If you're in rural Norfolk, you may be dealing with a higher proportion of traveller communities or Lithuanian communities because of historic economic kind of migration because of food processing in the east of the area, etc., etc. But you need to be very observant of that, because that's good, inclusive, non-discriminatory NHS care. And those two positions are a balance, and they're not in opposition with each other, and they work. And that's the same approach we take with everything, is that there's a absolute solid spine here, folks, of standards, great professionalism, leadership, adhering to guidance, really making sure you are professionally sound in everything that you do, the trust supporting you to do that, but change and adapt according to your local circumstances. And again, that's easy to say, quite hard to eke out, so you don't have people going off in other directions. And then I guess, Alastair, then above that, that's the whole essence of integrated care for neighbourhoods. So we will do the same with neighbourhood care. Most neighbourhoods, integrated neighbourhoods, are likely to be on the footprint of existing primary care networks. Not all of them, but most of them will. Where there's local authority boundary changes, that will challenge that slightly, but that's an issue into next year once those things have been finalised. And our teams are already locally based. They have the relationships. I guess what we will do as an organisation is potentially, and we're in those discussions with everyone at the moment, is then provide maybe the umbrella, provide the canopy of support, whether that's governance. We already provide, for instance, IT services to all the GPs in Norfolk and are about to do that in Suffolk. So we're already a partner with them to provide what they do. So I think you need organisations to hold risk, to work 24 hours a day as we do, probably hold some financial risk. Some primary care networks and GP feds will not want to do that, and therefore we could well be the partner that it works alongside them to make sure that happens. I think this is more my personal view. Integrated care at the neighbourhood level, for me, has to start with getting frailty right for those who are mild, moderate, and severely frail. It therefore has to traverse that there is a core general practice offer, which is mandated and negotiated nationally. There's then a local offer with primary care networks and the enhanced services. There's community services contracts. There's mental health contracts for older people. And if you then have the relationships, there's social care contracts, and there are obviously interactions with acute care. If we can get the construct right about those core requirements, saying, well, we need to carry on with those contracts, but wrap them into an alignment that we work together for the benefit of the local population that needs to be defined, it's not that hard to work how you can do that without being in opposition with each other.
Yes. So truly effective neighbourhood working, as you've just described, multiple organisations coming together with very different statutory footings, and in many settings, voluntary community, social enterprise, faith organisations playing a very big roles as well. In a sense, you can't mandate that from Department of Health. I don't think you can help contribute to the conditions, for creating effective integrated neighbourhood working. What do you think is the distinct role that your sort of organisation can play? You've talked about risk, holding risk, but beyond those things, is there a particular leadership role that you think you're looking for your trust to help in creating integrated neighbourhood working, particularly, say, around frail older people, as you suggested?
Yeah. So I hope the modern service framework that will be published at some point this year, and I hope isn't delayed, should set all this out. There's a massive evidence base about mild, moderate, and severe frailty. Mild frailty being something that is reversible if you get the interventions right. Moderate and severe frailty probably not reversible, and one needs to then put in the mitigations to support people to be as healthy and as well and as fulfilled as possible. And of course, with severe frailty, you are then into very clear advanced care planning and end of life care for all of those people. Just been through that process with my father, who died in May, and it's a tough old process, but it's essential we do that for everyone. Here's where I think we need to change our perspective. Is we need, at the integrated neighbourhood world, to do that for the totality of those who are mild, moderate, and severe frailty. So we both need to identify them and only identify them once. So the primary care record clearly is the best place to do that. So there's no point risk stratifying somewhere else, because actually the primary care record's got the most information in that we should be driving our data from. Secondly, we need to therefore say all of them are identified. You talked about faith groups and voluntary sector. I think, the three interventions around mild frailty, which are exercise, nutrition, and loneliness, are the three biggest determinants about whether we can reverse people's mild frailty. I think it's not a dietitian going out to see every single person. It's voluntary sector groups that we need to find mechanisms to fund and support. But we have to do it for the entire population, for the PCMs and the integrated neighbourhoods, not, we're doing it really well, but we're only doing it for 50 here, or we're actually only doing it for half the PCM. So we've got to industrialise this approach. And then for moderate and severe, it's outrageous. We know that the comprehensive geriatric assessment is the best tool, evidence-based tool that we should be applying to everybody with moderate and severe frailty, yet they're not shared, they're not developed, they're not then the tool that drives everybody else's interventions. So back to the question, what's my organisation? My organisation is one of the few that does 24-hour care in the community. It's one of the few that probably has all of those professional skills. I don't believe we need to lead everything, but we need to be, our staff need to be a core component and a core collaborator in all those areas. And if our organisation, which I hope is well led and respected in terms of what it does, can be a organisation that provides the oomph, the governance, the structure to allow some of those things to then be driven off those, then that's great. We will be there to do that. We're should be in the next few weeks get our advanced foundation trust status, because we've gone through our process with departments. So that also, it's a little bit emperor's new clothes. I probably shouldn't say that, but it is, because it doesn't bring us much, but it does provide the next stage to say you've got that stamp. Actually, you should be trusted to deliver more for the local population than you are doing at the moment. And for me, that's the whole point of Advanced Foundation Trust and integrated health organisations. It's not about, do you get kind of lots of things thrown at you? It's a stamp to say you are trusted to do something better in the future.
That's a good trust, it's a good stamp of trust within the NHS system. And I can imagine working with NHSE, with acute trust particularly, but obviously to fulfill the vision you've described, compelling vision you've described, obviously we've got GPs, primary care partners, we've got voluntary community sector partners, and then we've got local authorities who, as you've said, are going through lots of change. I was discussing with Charlotte Black, who I believe is a non-exec director of yours.
She is wonderful person that she is.
So part of it was, what's the perspective of local authorities and local councils on how do they read and understand the way NHS talks about integrated neighbourhood working, in a sense, even by talking about frailty as a clinical condition, I know it's a way of describing the proxy for people's needs that we can meet that will improve their outcomes. But how do we make sure we work with local authorities, both officers and councillors, in a way that ensures that we're getting the best of each other? Because they bring, in my experience, councils can bring quite a different perspective on the needs of populations and how you best, organise to meet them. And they've been under huge financial pressures, as you know, even more than the NHS. So I'm just intrigued a bit about, how you work with local authorities. And I know you do it very effectively. So I'll be intrigued.
Yeah. So it's not just, we've focused a lot on adults. The same would be true of children.
Yes.
And directors of children's services. I think of Sarah Tuff, just
yes,
brilliant children's director doing amazing stuff in Norfolk. But remembering that their neighbourhoods are very much wrapped around schools. And not around how the NHS thinks that actually neighbourhoods should be wrapped around GP surgeries or hospitals. Actually, for children and young people, it's a completely different dynamic.
Yes.
And we must remember that and actually ensure we do something about it. I think the two key officers in the councils clearly are the Director of Public Health and the Director of Adult Social Care, because both they've got the statutory responsibilities and they've got the leadership roles to make sure some of these things happen. And clearly, especially unitary authorities, it is a team sport because it's about housing, it's about leisure, it's about that totality of support. The NHS can only do a tiny part. But when it comes to those who are frail, councils will be commissioning those services for people to be moving, to people ensuring they have nutrition. I think where we've got to land together, and I don't think this is oppositional at all, is that we've also got to say we together as strategic commissioners and strategic partners are saying we identify the same people to be doing that approach. So, for instance, those that are lonely and isolated who are mildly frail, it may be that one source of that information comes from the council's bin collections where they know that they need to go out and move the bin for the person because they live by themselves and they're slightly immobile. Well, that's probably a very big factor for them. It won't show up on the clinical record, but something else will be shown up on the clinical record. And it's about fusing that data to say we are actually coming from different perspectives, but we're doing the same outcome, is that we don't want that person to be socially isolated. So this is all entirely possible. It comes down to us debunking and unraveling our discourse, our language, to say, are we talking about the same thing? We probably are, but from different perspectives. And secondly, I think it therefore gets into probably the hard yards of, okay, well, whose responsibility is this and who's accountable for getting on with this? And I think that's where this will fly or fail. We need people to be responsible and accountable for delivering the interventions around a frailty framework. And I'm agnostic about who that should be. It needs to be the right person who is passionate and skilled locally. And if that happens to be a primary care network clinical director, then brilliant. They may well be the best person. They may not want to do it and they may not be the right skill. They might have other skills, but we definitely need in the future people that say the population and ensuring that the evidence base happens and the interventions are happening for the totality of the population. We need an organisation responsible for that to make sure it happens, and we need clinical accountability. And that can wrap between health and social care. But without that hardness, we will continue to oscillate around, oh, it's okay in some bits, but it's not so good over here. And we're doing our population a disservice if we get to that point.
And obviously, there's a lot of talk nationally about social care policy with the new Prime Minister and the KC review, and the possibility of moving towards a more integrated, free at the point of delivery type service for social care as well as the NHS. That system is going to need new leadership capabilities. I mean, from everybody, but particularly for NHS leaders. So And as you said, the focus is on the outcomes for the population and ensuring delivery for them, but maybe being agnostic about who's leading it. That feels quite different from some of the traditional NHS ways of operating. So what do you think it means for leaders of the NHS, this future that might be unravelling over the next few years?
So I think the leadership is different according to where you are. Even if you're a leader in a mental health trust dealing with very complex adults and children who are potentially on the cusp of doing criminal acts, as we've had in Nottingham, we've had the attack in Huntingdon on the train. So that, you know, that really tough balance between violence and management of their conditions, etc. Your leadership task with councils is quite different than it would be in the space that I lead in, which is not doing that level of risk. It's doing risk around, actually, are we supporting everybody to have a great end of life? Equally as complex, but a very different conundrum, because we want to make sure everybody in a care home has a advanced care plan that we enact, and we do it on their preferences, and we stick to their preferences, and we don't then overlay a clinical oversight that does something different outside their preferences. All
Yes.
really tough stuff, but that leadership is a very different set of tricks and bags of tools that people need to leave. And then, you know, if you're in acute care, you're in a different world. You're in buildings, you're in central areas where you're managing flow of people coming to you, and you're doing other complex things. So I think we need to dissect what that leadership is in the space that we're talking about in integrated care. I think two things need to be really key. We need to empower and support and make people and support people to be responsible across organizations, and that may be, you know, contractually, you are therefore responsible contractually for a whole bunch of things, and therefore you need to have the mindset to do that. So I think we need to train people to do that, and our programs of training need to definitely focus on being horizontal and not just linear in your approach. And secondly, the incentives and the outcomes we need to achieve need to be far greater and better defined than they are at the moment. The NHS defaults very rapidly to a very reductionist conversation about what is the impact on emergency admissions into hospital and length of stay. You know, it's amazing how we can do that on virtually everything. You know, I've managed conversations both when I was working in NHS England plus when I've been a chief exec, is always that trickle feed of, well, what's the impact? I'm not saying that's not important. It's super important. But it's equally important to be talking about how quickly people are moving from being fit and well and mildly frail to becoming needing massive care packages and needing nursing care. That is still really important, because even if the government finds the money to pay for people's care, we've still got to question, should people be getting that care, or can we support them in a different way to make sure their care is cost effective and not high tariff? So it's easy to say the conversation about social care is being sorted by the new Prime Minister and Baroness Casey. I don't believe it is. The conversation about, do we have great integrated care that supports people to be fit and well at home and not need really expensive both domiciliary care at home or residential nursing care, is still the massive game in town that we need to get integrated neighbourhoods on. The how we pay for care is a separate issue, and therefore comes when a solution has been found. Doesn't take away from everything else that I've said needs to happen.
Yeah, I'm imagining that nationally they need to do some work to help create a framework on the financial side that might make it easier. To what extent do you think, just following that up, in the local places you are, there's a good understanding of the cost pressures and drivers on each partner? You know, primary care, the council, yourselves. I mean, I guess with the ICB. So I so often find NHS leaders, this is absolutely not true of you, Matthew, from what I know, but NHS leaders do not really understand the cost pressures that council leaders, directors of adult social care, directors of children's services are under, because it's a very different operating setup for them. with councillors, and they can't overspend in the same way that the NHS historically has got away with. So, to what extent do you think you and your colleagues have got that insight?
I would hope, and I would assume, so let's go with hope and assume that our integrated care board colleagues are fully conversant of total cost, because that's their role as strategic commissioners. But I think that's only part of the kind of question, Alastair, isn't it? We as leaders need to understand the impact on each other. And so I'm fully aware, just because of the role I do and the past roles I've had, about the cost of NHS continuing healthcare, whether that's for adults and older people, whether that's fast track at the end of people's lives, whether it's children's world. I'm fully au fait with the cost of the ambulance world and the UEC world and the unit price of acute care and my own services. I don't think we talk about the aggregation of that and the impact on each other. So it's easy to talk about, and again, I'm not saying people should stay in hospital. They definitely shouldn't. It's really bad for them. But when they say we just need to get people out, what we can't do is get people out into a setting that is overpriced, overpaid for their needs, and then drives long-term care cost unnecessarily for another part of the public realm, i.e. the council. And those silos still exist. We still overprescribe. We still, it is quite remarkable that we expect, where there hasn't been a cataclysmic event to someone like a stroke or a heart attack or a head injury, that someone who goes into hospital with relatively small needs is suddenly needing nursing care. We should be saying that's bad practice and we need to do something else. Now, I know I'm treading onto tough territory about discharge and all that in that world, an area that I'm very au fait with. But your point is salient. If people understood the impact on each other, I'm sure acute colleagues listening will say, yeah, what about the impact on my length of stay and corridor care and people not getting the care that they need? Absolutely. That's a hidden cost that we need to be really clear about. There's a cost of waiting for care. But I think I've not seen anywhere, and I certainly haven't seen it in my area yet, but I'm sure we will get there, is what is the total cost of our care on our population? And I think my final point is, if Baroness Casey's work is going to be impactful and we can afford, I think, can UK PLC really afford what's being put forward, because it needs to be paid for. So if we can do that, then we're going to have to unravel a whole bunch of things behind it. So why would we need a better care fund at that point? Question mark. Billions of pounds going into an artificial mechanism to try and drive integration. Very successful in some areas, completely not in others. NHS continuing healthcare often is driven because people don't want to pay their fees. If we've got free care in the social care sector, why would we be trying to get NHS healthcare to pay for that? Do you know what I mean? There are consequences of all that we will need to unravel behind to enable a different social care policy to come fruition. I think that's really exciting, but all of that unraveling and new design needs to happen at the same time, which is why this is not going to be a quick fix.
No, absolutely. And I suspect there's an awful lot of failure demand and failure costs in the system because of the lack of it being aligned and integrated. And continuing healthcare is a very good example. I think Section 117 aftercare costs, where people have been admitted under the Mental Health Act, there's a danger. I'm talking all from my personal experience with family here, but you see the disconnects of the system. I think if we take it back to what you've implied, which is about value, where that's about outcomes and experience for people and the resources required to do that, I think you end up with a very different view, which you've described through the frailty lens, I think, before, for integrated neighbourhood. So I think it's the challenge and the opportunity of almost reinventing how we deliver, how we support people to be healthy, and then we deliver care across health and social care in its broadest way in integrated neighbourhoods and places is a very exciting challenge. And as you said, there's a lot of unravelling as well as a lot of stitching together that I suspect is going to be needed there. So
let's just take NHS continuing healthcare for a second, which will be an alien concept to some listening, but this is the bit that the NHS kicks in at different points in people's lives and take responsibility for their total cost, often hugely complex children with massive needs and very complex issues, home ventilation, ventilated care, etc., etc. But it is developed through case law, it is developed through challenge to become, I would say, pretty dysfunctional and probably missing the point of what it was ever intended to do. And it's difficult not to get away. My father, going back to him, bless him, was in hospital for his last admission before he went back to his care home to die. We were trying to get him discharged, and there was a mantra about he's now into the end of his days, and he was, but just couldn't get discharged, although we got it sorted, because there was waiting for NHS continuing healthcare fast track funding. Well, he was funding his own care in his own care home. Actually, we were privileged because he'd used his savings, that he didn't need the funding. What we needed was the wraparound care to get him home. Now, I know that's not everybody's case, but it's completely missing the point. All we needed was the care home to move him from high residential up to nursing care level, which they did. Bless them, they did very well. And he died a couple of weeks later peacefully. But the funding was slightly irrelevant, because here's the rub. He got nothing separate from the NHS because of that, except his fees covered. He didn't get any end of life care specialist coming in to say, is your care good enough and supported well to die? The care home did all of that. So that's my bit about how bizarre it has come. And then for other people I know who are going home to die or having it initiated from home, we may well therefore get tangential carers coming in separate to their own care package, separate to their NHS care from, say, district nurses and their GP. So we could have 4 jurisdictions of care wrapped around an individual, when at the time we really need it at the end of their lives, it needs to be super coordinated. And that's all driven by different financial flows. And that's what we've got to redesign, is saying we've got all the money going in there, but it's like 4 different teams playing team sports in different pitches. Let's change that, because that will be better for our patients.
You are describing my father-in-law's last 6 months of life that we lived through last year. And, the carers that he was paying for, the specialist palliative care team, the GP team, and the community services team. And then you have out of hours. Now, in their own right, each were tremendous. They weren't all playing the same game with the same rules.
Yeah.
And
unconnected.
It was, and the true care coordinator would be my wife, his daughter, and probably in the same way. Now, we're articulate and blessed in so many ways that we can try and navigate this for our parents. But fundamentally, the system isn't set up, as you said. It's always going to be incredibly complex, but that's the challenge, I think. I mean, that's what you've described is what makes community healthcare, I think, and care at home a really challenging, exciting, important area of work, and why your trust has such a critical mission. So solving or addressing challenges like your father had and my father-in-law have had, that you can make a difference, can't you, in your trust? And I suppose just to give you a final closing word on that, Matthew.
Yeah, I think that's right, Alastair. And we do our public a disservice by not doing this. And I guess the other point is, when you asked me earlier, what's the challenge on leadership across all those areas? I think, we can only conclude based on this conversation, one of the challenges of leadership is at a provider level, not at an ICB level, but at the provider level, we have to support our leaders to design across boundaries and jurisdictions to get care better. And that's everything to do with negotiation. It's everything to do with arm wrestling. It's everything to do with changing policies. But it's also, at the end of it, it's about trust, and it's about relationships and an integrated neighbourhood. And you are aligning the needs of our population with what our different professionals and organisations are doing but all point in the same direction. It's soft and hard, and it's always going to be that soft and hard, but it has to be designed properly in the right direction. And leadership is about redesigning care.
Well, thank you so much. That's a great note to finish on. Thank you so much for joining us today, Matthew. Really appreciate your time. Thank you.
Appreciate it.